Hi, my name is Frances Faguy. Today I'm going to be presenting a primary research article published in the New England Journal of Medicine entitled Cabotegravir for HIV Prevention in Cisgender Men and Transgender Women. I'd like to begin with a little bit of background information on pre-exposure prophylaxis. Pre-exposure prophylaxis, or PrEP for short, involves an HIV-negative individual taking antiretroviral drugs prior to potential HIV exposure they may have from a sexual partner. One of these PrEP drugs is tenofovir disoproxil fumarate emtricitabine, or TDF-FTC for short, which is taken orally daily and has been proven to reduce the risk of HIV contraction. TDF-FTC is used as a control treatment in this experiment because it is a very commonly prescribed drug and because it is a daily oral pill, which is the usual model for PrEP treatment that people take today. Next, I'd like to talk about the purpose section of the paper, which tells the reader why the authors performed this study. The authors state that although there are safe and effective options for PrEP, there are still over 5,000 incident HIV infections per day worldwide. While some of these infections can be attributed to low access to PrEP in some countries, some of these HIV infections can also be attributed to people who do have access to PrEP but are unable to keep up with the daily pill regimen, who may miss a pill and thus become HIV positive. Because of this, the authors hope to see an increase in efficacy because they are testing an injectable drug, cabotegravir, when it is compared to the daily oral pill, the TDF-FTC, which is going to be the control group, simply because they're eliminating the daily pill. The primary goal of this study was to examine the efficacy of cabotegravir based on incident HIV infection, which means the total number of new infections in participants from the beginning of the trial to the end of the trial. They state their primary safety endpoint, which is an adverse event of grade 2 or higher, according to the Division of AIDS adverse events grading table, which denotes a moderate, adverse, or negative event. Next, I'd like to discuss the introduction section of the paper. The authors tell us a little bit more about cabotegravir. So cabotegravir, or CAB-LA for short, is a PrEP agent which has been previously known to be effective in primates. CAB-LA functions as an INSTI, or integrase strand transfer inhibitor, which is one of the most important drug classes that are being looked at for use as PrEP medications today. Cabotegravir specifically is considered long-acting, and it is injected into a patient's muscle tissue at a dose of 600 milligrams every 8 weeks. The authors cite a study by Landovitz et al. Saying that, quote, CAB-LA has potent anti-HIV activity, protects non-human primates from a broad range of HIV exposure types, and is generally safe in humans. Next, I'd like to discuss the materials and methods section using Figure 1, Parts A and B. Figure 1, Part A is on screen, and it shows the trial design chronologically. The trial began with an oral phase, which was double-blinded, meaning neither the healthcare providers nor the patients knew whether they were in the control group or the cabotegravir group, and thus neither knew which medication they were taking. Both groups received oral pills during the oral phase, and this lasted 6 weeks. Next, the injection phase was also double-blinded, and this lasted up until week 153. Both groups, again, received a placebo as well as their assigned drug. At week 153, the study ceased to be double-blinded and became instead open-label. This marks the beginning of the tail phase, and patients were made aware which medication they had been taking. On screen is Figure 1, Part B, which shows the screening, randomization, and follow-up process of patients. Patients were considered eligible if they were either cisgender men who had sex with men or transgender women who had sex with men, and if they were HIV negative. People were excluded from the study if they had kidney or liver problems, as that could pose a safety issue. At the beginning of the trial, patients went through eligibility testing, which included hepatitis A, hepatitis B testing, hepatitis C testing, and HIV viral RNA testing to ensure that they were not HIV positive. 2,247 people were assigned the TDF, FTC, or control group, and 2,243 were included in the primary efficacy analysis of the Cabotegravir group. I'd like to use figure 2, parts A and B, to discuss the results section, which tells us what happened numerically during the trial. As you can see on screen, 13 out of 2,243 Cabotegravir recipients contracted HIV during the study, which is a rate of 0.41 per 100 person years. And 39 out of 2,247 TDF FTC recipients contracted HIV, which is a rate of 1.22 per 100 person years, approximately triple the rate of Cabotegravir recipients who contracted HIV. Figure 2, part A, is on screen. The most important part of the figure is highlighted in the red box, and that shows that the cumulative incident HIV infection over time is much higher in the TDF FTC group than it is in the Cabotegravir group, starting at about week 15. And this is very consistent throughout the rest of the trial, which agrees with our the previously discussed data, which is that the TDF FTC group overall had a much higher rate of HIV contraction. This is figure 2, part B on screen. Again, in the red box is the part of the figure I consider to be most important, which constructs a hazard ratio for Cabotegravir and the TDF FTC or control treatment. I will discuss the hazard ratio a little more in a minute because that is mostly for the discussion section of the paper. But what this graph shows is that across every demographic you can see on the left side of the screen, age, gender, race, and geographic region, Cabotegravir performed better, and Cabotegravir recipients contracted HIV less often than the control group. This is figure 3 on screen. It shows pharmacologic and virologic data for HIV infections in the Cabotegravir group only, so excluding data from the control group. You can see group D at the bottom of the screen is highlighted in red. Group D represents the 4 individuals in the trial who were dosed appropriately with Cabotegravir before they contracted HIV, who were dosed at the appropriate times with Cabotegravir before their HIV contraction, and had the appropriate concentration of Cabotegravir in their blood plasma at the time of HIV contraction. So group D really shows the individuals for whom Cabotegravir was administered appropriately and correctly during the trial who still contracted HIV. So group D really shows the 4 individuals in the trial for whom Cabotegravir failed in a sense. On screen is table 1. It shows the demographic characteristics of the participants at the beginning of the trial. You can see highlighted in the red box at the top that the majority of the individuals in this trial were men who have sex with men, and also that the vast majority of individuals in this trial were aged 18 to 29. I think this is the most important part of the demographic characteristics because it shows that the participants were well selected for the trial, because a large proportion of people who do take PrEP drugs and who are at high risk for HIV contraction are men who have sex with men, and many of them are young, so under 30 years old. This is a continuation of table 1 on screen. You can see highlighted in the red box. I selected the data that shows that the majority of individuals in this trial were considered single, divorced, or widowed, approximately 82% of them. I think this is important because this is the only group of individuals by marital status who do not have either an exclusive partner or a main partner. So this to me indicates that this group of people likely had multiple partners, which puts them at a high risk for HIV. So again, the main takeaway from this slide as well is that the participants of this trial were well chosen, in my opinion, and well representative of the people who would take this PrEP drug. For the discussion section of the paper, the authors constructed a hazard ratio for incident HIV infection between the cabotegravir group and the TDF-FTC group. This is a ratio of 0.34 to 1, meaning that for every infection in the control group or the TDF-FTC group, there are only 0.34 infections in the cabotegravir group. This represents a decrease in incident HIV infection of 66% for the cabotegravir group. They also constructed a hazard ratio for death from cabotegravir to the control group of 0.57 to 1. So for every death in the control group, there were only 0.57 in the cabotegravir group, which represents a decrease by 43% for those taking cabotegravir. Another very important aspect of the discussion section is INSTI resistance. Again, the drug used in this trial, cabotegravir, is an INSTI drug. So INSTI resistant mutations in HIV infections can obviously show that the INSTI drug overall may be very susceptible to mutations. It's very important that there is a low rate of INSTI mutations among the people who become infected in this trial. So note that only 1 of 4 baseline HIV infections and only 4 of 9 infections with a resistance test result involved an INSTI resistant mutation. So that is a minority of infections. The final thing I'd like to look at is the adverse events table, which is on screen. Again, the primary safety endpoint of this trial was an adverse event of grade 2 or higher. So this is what the authors of the study consider most important in terms of safety. You'll notice that individuals in the cabotegravir group have a rate of adverse events of grade 2 or higher of about 92.4%, and that the control group has a rate of 92.7%. So these rates are really almost identical, which shows that there was not a large difference in safety between the cabotegravir drug and the TDF-FTC drug, which again is already being prescribed. So the authors of this study conclude that, quote, this trial showed that CAB-LA was superior to TDF-FTC in preventing HIV acquisition among MSM and transgender women who have sex with men. So the authors of this study thus believe that CAB-LA is potentially a superior method of PrEP than TDF-FTC at preventing HIV infection, and they state that cabotegravir should be studied much more extensively to evaluate not only its efficacy in preventing HIV, but also its safety for use in humans. This is where both the primary research article and my presentation leave off. This last slide has all of the references I used for my presentation, and thank you so much for watching.